I'm Dr. Constantine, and I'm here representing myself and my associate, Dr. Rohan. We are Hudson Valley surgical specialists, and I'm here to talk to you a little bit about reflux, gastric reflux. I hope that that's not what you're experiencing from the food.
Could you speak into that mic?
Sure, sure. Okay, so a lot of us have reflux, and I would like to touch upon what is gastric reflux or GERD, what is the medical or surgical treatment, and what is this new thing called incisionless surgical therapy. So like I said, a lot of us have heartburn, and usually heartburn is caused by reflux of the stomach acid into the esophagus. Do you have a pointer? So the acid regurgitation, the acid going up from the stomach into the esophagus is stimulated by large meals. People may have this water brash, like a hot sensation in the stomach, maybe associated with excess salivation, problems swallowing the food, or pain with swallowing, but also other things that might not be as obvious as what I said before, like asthma. Some people with asthma actually don't have asthma, have reflux-inducing asthma symptoms. Aspiration pneumonia, because the reflux from the stomach can go as high up as the neck and then drop into the windpipe. It can cause pneumonia. Chronic bronchitis. Other problems like chest pain, regurgitation, dental erosion, or even ear, nose, and throat issues like hoarseness, laryngitis, chronic cough, frequent swallowing. And this is what happens, basically. I'm going to use the pointer here. Normally, between the esophagus here and the stomach, there is a valve such that the acid secreted by the stomach doesn't go up. This is a section through the stomach showing basically the same thing, showing that the clearance of acid stops here between the esophagus and the stomach. And then there are a bunch of other factors, not only this little valve that help us fight with the hydrochloric acid that is secreted by the stomach, like the mucosal resistance to acid, the ability of the stomach to empty, because the stomach is not just a pouch, is a muscle that squeezes food through into the small bowel. And there's something else called duodenal gastric reflux, when stuff from the duodenum, from the small bowel, like bile, can drip back into the stomach and cause bile gastritis. So normally, this is what we have. We have the muscle of the diaphragm, the chest is above it, the belly is below, and the stomach is below, together with like 1 inch of the esophagus right here. And because of this valve and the difference between the pressures in the belly and in the chest, the normal anatomy prevents acid from going up. When the gastroenterologist takes a look in there, this is how normal anatomy should look like. This is the scope. The black thing is the scope of the gastroenterologist introduced, and then turned around like this, and he's basically looking at the entry point, right? It's like a J. So you can turn around this scope, just like so, like you see here, and take a look at the entry point. And you see this valve is nicely around the scope. That's normal anatomy. Let's see what happens when the anatomy is not normal. Comparing normal with abnormal, you see this, the valve is gone. The connection between the esophagus and the stomach is very loose, and what the gastroenterologist sees is this. The same, by turning the scope around, the same scope and the same orifice is just that it's open. You see there's a gap between the instrument and the wall of the stomach, right there. So if this valve cannot hold properly the scope of the gastroenterologist, it's not going to be able to hold the acid down either. So there are about 15% of adult population that suffer from daily GERD, but there are a lot more people that suffer from GERD, and the more we grow in our weight, the more fat we gain, actually the higher the prevalence of reflux in the population. And the more it happens at younger ages. So the incidence of reflux rises rapidly after 40 years of age. Most refluxes get worse over time. There's another thing that is important to note. The esophageal cancer is 8 times more likely to occur in patients with weakly heartburn and regurgitation, and this is because the mucosa, the inner wall of the esophagus, is not supposed to have to deal with acid. The moment it starts to deal with acid, with daily acid, it transforms from the usual cells to intestinal-like cells, and then those can degenerate into cancer. So there is a reflux that is physiologic. So everybody at some point is going to have some acid going into the esophagus. So that's nothing wrong with that, and that doesn't turn into cancer or anything like that. The next step is symptomatic GERD. That's when somebody has acid reflux and starts feeling it. Whether it's heartburn or regurgitation or bad breath or chest pain or cough, asthma or laryngitis, it doesn't really matter. This is what happens the moment the reflux becomes symptomatic. Then the next step is esophagitis. Itis means inflammation. So it's inflammation of the esophagus. So when the gastroenterologist takes a look in the esophagus, he's going to see redness, inflammation of the end of the esophagus because of the acid going up. The next step is complicated esophagitis, when instead of just redness, the gastroenterologist is going to see an ulcer there, or he's going to see bleeding there, or he's going to see tightness, or he's going to see this thing called Barrett's esophagus, which is exactly what I was telling you, degeneration of the wall, inner wall of the esophagus into something else that is the precancerous condition. And the next step might be cancer. That doesn't mean that everybody that has reflux is going to end up sooner or later having cancer. I don't want to give you any false information. I don't want to scare you either. All right, so that's basically the one-on-one on what GERD is. Now, how do we treat GERD? Well, a lot of us are on proton pump inhibitors, PPIs they're called. Those are daily medications for people that suffer from peptic ulcer disease or gastritis or reflux disease, and they're known to get the symptoms better. Let's see if that makes sense. Before that, other things that can be tried and should be tried are diet, for instance. Dieting for any reason is always good. You know, whether it's dieting for the reflux, dieting to lose weight, dieting and having more fiber because I have diverticuli in the colon on my last colonoscopy, and I need more fiber for that, or I need more fiber because my cardiologist told me that I should have more fiber in my diet so that I decrease my cholesterol and all of that. Basically, all of these things are going hand in hand. So weight loss is important. No late night eating, that's very important because it's a known fact that when people eat and then go straight to sleep, they're going, a lot of times they're going to have reflux. The bed position and the number of pillows. This is a question that I always ask my patients. How many pillows are you sleeping? You know, when I see somebody in my office for evaluation for the surgical treatment of reflux, that's one of the questions that I'm going to always ask, because what I'm interested in is, one, if everything else was tried before surgery, and two, how uncomfortable the reflux makes the patient. How much does this disease affect the patient's lifestyle, the family's lifestyle, and everything. A lot of them are going to tell me that they're sleeping in a chair. You know, and especially when I see somebody in my office and I have a bunch of people that are teenagers, you know, they're 19, 20 years old, and they've been having reflux for 6 years, and they already sleep in the chair. There's not much hope short of surgery for patients like this, right? So, medications, antacids like TUMS, right? Those neutralize the stomach acid. You combine a salt with the acid, and the result of the chemical combination is better for the gastric mucosa than what you started with. H2 blockers were the first big blow to gastric surgery. When I was training and I was in my medical school, every general surgeon would probably do where I was training 4 or 5 gastric resections a week because there was no other treatment. Then cimetidine came out. And cimetidine basically turned everything around because that started the medical treatment of gastric ulcer, peptic ulcer disease, and made it better actually in some instances than surgery.